So, with everyone's permission, I'm starting with today's session now.
Start the recording.
Greetings. Yes, sir, it's on. Greetings and a warm welcome to all the dignitaries present here. I'm Shwastika from Team Clearnet, serving as the allocated session assistant to ensure a seamless experience. Clearnet is India's most trusted and widely used digital platform, offering a multitude of imaging services exclusively for doctors. Clearnet is slated to be chosen as a digital partner for this event organized by Indian Association of Preventive and Social Medicine. So today's focus would be biomedical waste management. And now I would like to hand over the session to Dr. Animesh Jain sir to take over. Over to you, sir.
Am I audible? Because I see that some freezing thing in my Zoom. Am I audible?
You're audible, sir,
Sir,
but we
you're
are not able to
audible,
see
you're
you.
not
Okay.
visible.
So yeah, so that's okay. That's okay. That's what. So good evening, everyone. On behalf of Indian Association of Preventive and Social Medicine Karnataka chapter, IAPSM Karnataka chapter, I welcome you all. President of our chapter. So I hand over to Dr. Poonam for her opening remarks, and then we'll take it forward.
Thank you, Dr. Animesh. So firstly, let me welcome all over here on behalf of Karnataka chapter of IAPSM. And thank you, Dr. Saurabh, for accepting our invite and delivering this important session. So this particular session will be of great importance for the postgraduates, especially with biomedical waste management, both from theory as well as practical point of view. It would be useful for them. And I'm sure your session, as always, would be very effective and efficiently delivered. Thank you, Dr. Sir. Over to you, Dr. Anish. Dr. Animesh?
Yeah, I'm back. Sorry.
Yes.
There was
Yes,
some
yeah.
issue, I don't know, so I just rejoined.
Okay.
Yes, so yeah, welcome back again. And we have a very interesting and very important topic today, that is biomedical waste management. And personally speaking, I feel that every healthcare professional should have some idea about this topic, irrespective of whichever field we are in. And to do this today and to give us some more insights into this topic, we have Dr. Saurabh Kumar. Dr. Saurabh Kumar has been known to all of us, including Dr. Poonam, myself, Asha, and others, because he's been a very, very important member of our IAPSM Karnataka chapter. And he was in Mangalore, where we are based at, Dr. Poonam and myself. He was in Mangalore some time back. Currently, Dr. Saurabh is based at KLE JGM Medical College, and he works as a professor and head of Department of Community Medicine there. I think since last 2 years or so. So February 23, he moved in there, I think, or something like that, or May 23, he moved in. He also holds multiple other responsibilities and wears multiple hats, including being the State Task Force TB Karnataka's chairperson, TB's sub-national certification state nodal officer for Karnataka for 21-22 and 22-23. He's also national master trainer for HIV/AIDS counseling issues under the GFATM round 7. And he's got multiple other responsibilities. He's been resource person for multiple things, including RNTCP, HIV, and he's a certified Jeev Raksha senior instructor, which is a very Indianized form of BLS, ACLS, or maybe a little step ahead of that. Other than that, he's worked during COVID times as an institutional COVID-19 nodal officer when he was in Bangalore and Father Muller's. Currently, he also serves as the member secretary of Institutional Ethics Committee at KLE JGMM Medical College. And other than that, particularly pertaining to the topic, Dr. Saurabh has actually, from his PG time, had shown very keen interest. He was instrumental in training lots of people in his previous institution during his PG time, that is IGMC Shimla. And he was very keenly involved in all those trainings, including nurses, paramedics, and other people. That's what he was informing me just a few minutes back. And other than that, when he was in Father Muller's, during that time, they used to prepare reports and send it to the director, and very regularly and periodically. Other than that, currently, he is also the co-convener of the Towards Unity for Health Center for Excellence South India. And he's also the moderator for a fellowship program, which under that particular Center for Excellence has been started, Social Accountability Fellowship. So I have been a resource person for that, and Dr. Saurabh has been kind enough to give me that opportunity as well. He has multiple memberships, including IAPS in Karnataka and IAPS in national level and IPHA and others, including that and Catch. So he's been a member of multiple organizations. He's quite experienced with more than a decade, 14 years post MD, has 28 publications. He's been on the editorial board of several journals, reviewer for many journals. He's conducted trainings and conducted lots of workshops and CMEs. I think the list will go on, but as I said, he's quite an accomplished person, and we have him today, and I'm looking forward to hearing from you, Dr. Saurabh. Over to you.
Thank you very much, sir. At the outset, I would like to thank the Karnataka IPSM chapter, Poonam ma'am, Dr. Animesh sir, Dr. Asha, for giving me this opportunity to be a part of this IIPP sessions. In fact, when I was in Mangalore that time, I remember like it was initiated by Kulkarni sir on the IIPP session for the PDs, and we used to have it more of, it was used to be in an offline mode, and it was definitely a big success for the postgraduates, especially learning for the postgraduates. Okay, as sir has already mentioned regarding my presentation that I was involved for biomedical waste management during my postgraduate time. So I thought like when it comes to the guidelines and regulations, they're already available on the internet. So for the postgraduates and the staff to go through, go about it, go through those presentations and the regulations. I just wanted to add some of my experiences, like what we had during my post-graduation when I used to train the nursing staff and housekeeping staff. They were the most commonly affected one when it comes to the hazards of the biomedical waste management. And we, as sir also mentioned, we took it up as a challenge when I was working in Father Muller. So once in, 2 months, every 2 months, we would submit our report of the institution hospital waste management to the administrators. And we saw definitely there was improvement. Yes, NABH, NABL also was a component of it. But students also were trained as the future interns and the future postgraduates, how we are supposed to go for biomedical waste management. It's not just about only community medicine. Almost every doctor, every healthcare worker should be knowing what are the rules and regulations of the biomedical waste management. So with that background, I'll just share my small presentation with the, just 1 minute. Let me make it as a slideshow mode.
Recording in progress.
Okay. Now coming back to this, the outline of this, I am just looking at some interaction from some of the postgraduates who have joined right now. What is wrong in some of the photographs which I'll be sharing with you. To some extent, historical context which you're already aware of, and hazards and the principles and steps, and what additional things which I found was required during our research in biomedical waste management. Challenges many of us are aware of. I'll just have added a little bit of COVID-19 challenges also post COVID-19, what challenges we have in biomedical waste management, and the way forward, what the 5-pronged approach we can take up, and also like what is the role of community medicine, physician, or you can say a public health specialist when it comes to biomedical waste management in a medical college setting. So now I think we have few postgraduates with us. Can just anyone put it up in the chat box, or like what do you think is wrong in this particular image? We have highlighted with the yellow arrow also in this.
Either participants can unmute and respond or can type in the chat box also.
They can write in the chat box, ma'am. That should be fine. Okay, in simple words, like if you're hesitant enough, like hesitant in putting up your words or points in this case, you look at there is plastic, there is a blood, and there's general waste. So talking about the mixed waste in this particular image. And one important principle which we always talk about in biomedical waste management is the all or none phenomenon. In the coming slide, you will be seeing that when we say about biomedical waste management, we usually say it's around 75 to 85% waste what is generated in the hospital is usually non-hazardous, not leading to the infectious disease, not leading to injuries to the various stakeholders. But around 15 to 25% is definitely hazardous or infectious, and we should be ensuring that they are compartmentalized, they are segregated. That becomes the very important pillar of biomedical waste management. And if that itself is not there, just imagine, look at your own cities, wherever you are right now, and where they collect the waste of the entire city, and finally they'll be dumping it. Later on, they're going for the multiple processes, the decomposition of that using the either this uh, chemicals in that case they'll be using, or they'll be using like some of the yeast also to decompose the municipal waste. The challenge what the pollution control board gets the call from the corporation thing, and there's always will be a fight between them that the hospitals are not segregating the waste correctly, and when it is coming to the corporation area where the landfill areas are there, the workers are getting exposed. And I always used to put this question to my students and interns: as doctors, as healthcare workers, do we think that only providing the healthcare in the hospital settings or in the primary health center settings, any healthcare settings, is the complete job of a healthcare worker? If we look in that way, that we are only providing the healthcare services, then we're having a tunnel vision. Why I say tunnel vision? Because the waste which is being generated, if it is not segregated, somebody is going to become either hepatitis B positive or HIV positive, maybe tetanus or typhoid, anything. And in fact, in my journey of this biomedical waste management trainings and the research, when we interacted with many of this housekeeping staff who used to carry this waste from the wards to the central storage area, they just used to literally cry, saying that, "Sir, we have been stuck multiple times by the needles. Why doctors are not keeping the waste correctly? What we have done wrong? Because of somebody else's mistakes, we are suffering." And believe me, quite a many of the housekeeping staff members turned out to be hepatitis B positive. We cannot prove the causality, like in this case, whether it was because of this needle stick injury. They had some symptoms later on, they were tested and they came to be hepatitis B positive. But just hypothetically assuming that it was because of the injuries multiple they have received during the course of their duties or responsibilities of carrying the waste in the hands, not even in the trolleys. Many times trolleys were not available, and the area was, the trolleys couldn't have been used in such places because there was a descent and then the ascent, when they were carrying in the hands only. So finally, who is responsible? That's a big question mark, and I'll come to that question again for you in the coming slides. Just look at this again. We are talking about the yellow colored bins, yellow colored bags, and what all types of waste is there in this. Again, a mix of all the waste, what we can see in this. We have plastics, we have general waste, we have needles, we have syringes, we have gloves. Everything is put up in this case. And again, who is responsible for this? We as healthcare professionals only. And unfortunately, our focus always has been on that we need to train the housekeeping staff more because they will be carrying the waste. I worked in multiple institutions, and when we used to visit other institutions for as a part of like other TV activities, other activities, and I always used to keenly observe the biomedical waste. And in fact, in recently when I was completing my ACMA, so one of the project also which one of my fellow colleague had taken it up, it was trying to focus on the nursing staff and trying to focus on the housekeeping staff, the responsibility of segregation, and not on the doctors who are one of the main persons who will be the generators of the biomedical waste. So it's a high time we need to look at. It's every stakeholder is equally important when it comes to the biomedical waste. And we as healthcare workers, doctors, nursing staff, technicians have more responsibility when it comes to biomedical waste management. The first step, that is segregation. Again, you can see how the waste has been thrown and mixed with the corporation waste. So when I was talking about all or none phenomenon, I'm talking about this now. The entire waste of the city at one place and the infectious waste of the hospital, any hospital, I don't know which hospital this is there, because we have been to the landfill site also and we have taken the pictures too of that place and then found that they were complaining, sir, like this all waste will be coming, what to do about this? And the entire, and just assume like this waste is getting mixed, so it becomes completely, even the municipal corporation waste also what we have will become completely infectious. Okay. Again, have a look. What is the color of the bin and what is the color of the bag? So that one is the guidelines we need to have it like the bin and the bag should be of the same color. And again, it's a mix of the things, whether it's the blue colored where we are supposed to have the glasswares, there's something else have been thrown. Again, a similar picture, general waste along with the needles and syringes is it thrown like this only in the waste bins. And though for the image purpose, like, yeah, it was taken by one of my colleagues, we should not be removing the waste from and looking at segregation. And unfortunately, this is what I observed in many of the hospitals in the beginning, and then you used to give the recommendations, please don't do that. Okay, yes, it has been mixed. Please do not segregate the waste after it has been already mixed up. We are not like reducing the infection in this case. Basically, we are going to increase everything. We're going to mix up the non-hazardous waste also with the hazardous waste later on, which you don't want to do it. I've already written. What is it? Any guesses? Is anything wrong with this? This is a pyrolytic incinerator plant and had two chambers. So what you're looking at basically in this case is one of the chambers is visible and it is opened up. And when we interviewed the workers, not just one institution, multiple institutions where we had this incinerator plants, nowadays, it's not there like in all medical colleges. Please remember this. Previously, it was a guideline of NMC, at that time, sorry, erstwhile Medical Council of India, that each and every medical college should have an incinerator plant also. And it used to be one of the remotest possible location of the medical college. But not all medical colleges had though, even that point of time. So now, I want to highlight in this case is we talk about, yes, non-chlorinated waste bags, non-PVC waste bags in which the waste is being collected and put up directly in this incinerator plant. The challenge is reaching the temperature of 800 degree and the primary chamber and secondary chamber of 1200 degrees Celsius. And if you're not able to reach that chamber, and if it's a mixed waste, we are looking at a lot of challenges. One, for example, if the temperature is not reached, a lot of moisture is there in the waste, what is coming up, because we have mixed the municipal waste also in the infectious waste, what is supposed to be going in the incinerator plant. The challenge will be more of uh, incomplete combustion of the fuels and then the various dangerous gases like dioxins and furans being released. And that have been found to be attributing to cancers. That is one. Okay, that is for in public, if I say. And that's the reason I told you, like it used to be in the corners of the, you can say, remotest corner of the medical colleges previously. Now, the challenges which I felt, which we observed when we interviewed these workers were because of the mixture, or you can say the khichdi prepared by the healthcare workers in throwing the waste in whatever bin they like. These people had to literally mix the waste using an iron rod, a wooden rod, something like that many times, and again close the lid of incinerator plant. Now, a simple question. What happens if we heat a glass vial or ampule, keep it at very high temperature? It may melt. Yes. It one of the things which may happen, it may burst also. and those will be like high velocity projectiles. And all these workers who are working in incinerator plant, they complained, or you can say they reported, that they had got multiple glass injuries because when they used to mix this waste, these glasses and the sharps used to come as a projectile and have hit them. On the face also, even in fact, they have hit them. There is a different story itself. Maybe they're like workers were not wearing the biomedical waste, personal protective equipments. But again, the question is, who is responsible for this mixing of the waste? So this is you're looking at the chimneys of one of the incinerator plants, and as I said, preferably it has to be somewhere in the higher settings, but in some of the places which we visited, it was on the lower level, and there were quite a few households nearby. And that becomes the biggest challenge. Why I'm saying a challenge again in this case, it was the common waste management facilities which we visited. And if the houses are on the upper level and this is on the lower side, finally this, because of incomplete combustion, the gases leading to air pollution, the people in the nearby houses are going to get affected. So we had to give the recommendations, please shift it. But again, it's up to the government. We can just put the recommendations. Let's see what happens further. Okay, now this is looking at some pits, the sharp pits, where the sharps were like sharps usually comprise of less than 1% of the biomedical waste what we generate in the hospital. It's roughly about 1.5 to 2 kg per bed per day. If all the beds are occupied in general, when we say the amount of biomedical waste generated in the hospitals. Though in COVID times, it increased to almost more than you can say 150% of what it was coming up previously. Again, what is wrong in these sharp pits? Any guesses? The holes are quite big. In fact, a small kid also can fall in that, but usually no kids were allowed in that region. Small animals also probably, if they're like going, they can fall in that. It is not in the scientific principle of having the sharp pit, but we need to have a conical tube connected to the opening of the sharp pit, and we need to have the regular disinfectant solution to be placed in, to be put in this sharp pit, which was again not happening in this one of the pictures which I have showed to you right now. This definition you're already aware of, so I'm not going in detail. There's diagnosis, treatment, immunization, or research. So whatever waste material we are generating, it's as per the Government of India's Gazette, it is called as biomedical waste. And then, as I told previously also, 85% is non-hazardous, but we are more worried about this 15%, and if it is mixed with the 85% at any point of time, from one of the ward also, if it is going, the entire 100% becomes infectious or hazardous. So that's what I've been stressing. Biomedical waste is all or none phenomenon. You cannot say that 60% of the people are following the guidelines, or 40% of the people are not following the guidelines, 70% are following the guidelines. Even if 30% are not following, the waste which is coming from the hospital is going to be, I'm talking about the entire waste is mixed up. Even the corporation waste, general waste, what is coming up from the hospital, that also will be infectious waste. This is which probably you can get on the internet also. I thought like I'll just take the liberty of putting up this timeline for you. When we got worried about this biomedical waste management, healthcare is going on since centuries together. Allopathic system is working. Now the question is, we were concerned about this biomedical waste management when the HIV started rising. So 1980s, when we looked at a lot of syringes, needles were getting washed up on the beaches. And then in the USA first, they came up with the Medical Waste Tracking Act. So India also 1986, in fact, under the Environment, your Protection Act of Ministry of Environment, they thought like we need to think about on the hospital waste management, but it took a long time to actually come up with the biomedical waste management handling rules. See here, 1986, we the ministry thought we need to have some rules and regulations regarding this. And 1998, we were able to effectively come with some rules and regulations. And again, there was some relaxation given to the institutions. Please take some time. By 2004 and 5, we should be able to implement it, because straight away we cannot go for any punitive actions against the institutions. Now, again, in Indian context also, it was mainly because of the HIV. That was the reason, like the thought, like we need to go for, and there were a lot of public interest litigation which were filed. Not really remembering the name of the agency in Indore which had filed this. Madhya Pradesh or in Delhi also there was a public interest litigation that regarding the scavengers or the people who used to collect the waste. Collect the plastics and all from the waste and then used to sell it in the market. And seeing those pictures when the NGO had approached the Supreme Court and said, yes, we need to come up with the guidelines, but still it took a long, long time to come to for the Pollution Control Board and the government to come up with these guidelines. Then it was a long, long time, and again there were not changes much. There were 10 categories of the waste, and still a lot of scope of training of the people, retraining, refresher trainings were required. Again, the changes came in 2011 when thought like we need to have some modifications. 2011, the reduced the number of categories of the biomedical waste from 10 to 8. And then 2016, 2011 guidelines, please remember it was a draft document which was released. And then 2016, actually, the final, they came up with the new guidelines again, where instead of the from 10 to 8 they had made and then 8 to 4 categories were made, though the type of the waste remains the same. So I'll say like basically we're talking about an old wine in new bottle only when it comes to the guidelines. Yes, but there was more stress on going for some advanced technologies for management of biomedical waste, like having the microwave irradiation also, but that's very, very difficult. In fact, most of the settings where I have seen, they don't have this microwave irradiation management or microwave treatment of the biomedical waste. Autoclaving, yes. Incineration, yes. Maybe disinfection, and then going for shredding is a commonest thing which most of the common biomedical waste management treatment facilities will be having it. And then COVID-19, which I think took all of us for a ride. So we say 19, but I think it affected us in 2020 and 21, where all of us maybe have lost somebody either in the family or in the relatives. It was infectious waste, talking about using the PPE, person protective equipments, and disposal of that, dead bodies disposal. Everything was coming as a this thing you can say a challenge for all of us. But post COVID-19, I think biomedical waste management has thrown up a newer, you can say, challenge to all of us. What about the waste, what we're generating in the houses? In fact, that was always the question which I used to raise. We talked about like having the wet waste and the dry waste in the houses. But what about the sanitary napkins? What about the diapers? What about the dressings? What we're having in the houses? The every alternate house. In fact, I was working in the Faramala Medical College, Mangalore, and we used to go for this family survey in the field. We observed in some of the areas, every third house there was a diabetic person, and out of them like 30% of the patients were on insulin as well as American tablets too. So when they're using this, again talking about infectious material, the cotton soaked with the blood and all is going in the general waste itself. So challenge, we are still not able to come out of managing the hospitals itself in a proper way, and we're having the increased, you can say, waste generation, that the biomedical waste generation which is coming from the homes also. COVID, we didn't have a separate guideline. There was just an, you can say, new regulations were like issued and informed to everyone that we need to go for double packing of the waste which is coming from COVID-19 wards, especially in the hospital. Some of the salient differences what we had in 2011 and 1998 regulations, mentioning about the number of the beds. And in 2011, it talked about that every occupier means every healthcare facility, irrespective of the quantum of the waste, and duties of the operators, which either collect or which are incinerating it, which are autoclaving it or shredding it. Operators will be coming in that list. I'll be showing in the coming slide. And operator duties was absent in 1998 guidelines when it came. So categories, as I told you previously, were reduced to 8 in the draft guidelines though. And as said, discussed previously, it was made for all the healthcare establishment instead of just focusing on more than 1,000 beds. Format for report, and there are multiple forms in this case, which was absent in 1998, came up in 2011. Again, 2016, similar things came up. The main difference, what you're looking at is Instead of 10 categories finally of 1998, which was reduced to 8 in 2011 draft guidelines, came to as 4 categories in 2016. Some changes were there in the various schedules of biomedical waste management rules and regulations, and even in fact Ayush and almost every hospital as a part of KPME now it's online only. So we have to submit the biomedical waste management certificate from the Pollution Control Board. It's mandatory now for any healthcare settings. So looking at from the hospitals and nursing homes, even to health camps also it is going to apply. That's what they look at. If we have going for camps also, we need to ensure that we have proper uh, collection of the waste from the, and they should be discarded in the hospital only afterwards. The definitions of your occupier, operator, and the prescribed authorities. So just have a look, like there are people who are going to collect, I mean agencies. It has most of the institution nowadays outsourced because it's not cost effective to run the common biomedical waste management treatment facilities in a medical college settings. So if the multiple hospitals are together, so usually we go for a collaborative thing. So agencies have taken it up and they'll be charging the institutions depending upon the waste generated. And every year, in fact, it will be renewed. So like few agencies, I think we had the Ramki agency in Mangalore and Karnataka's many places. And like if you look at in Hubli Dharwad and Belgaum area, we have the Rio Green, one of the agencies which is looking after the biomedical waste management. So every place have, and like almost all the hospitals will be having a tie-up with them when talking about the collection of the waste from the nursing homes or the hospitals or the medical colleges. Um, Treatment and disposal, usually these agencies like have to take a special permission to actually visit those places directly. They won't be allowing us. And when coming to transport, yes, transport has got two components, which you'll be seeing when I talk about the various other steps at the institutional level. That is intramural transport and the extramural transport. So intramural transport, we say like it's within the institution when we are sharing, I mean, transporting the biomedical waste. And extramural when it is transported from the hospital to the place where it has to be disposed of. And usually it will be that agency, they'll be coming up with the vehicle where they're going to collect the waste. Now, looking at this slide, hazards. I've already spoken regarding few of the hazards and my experiences when I used to interview the housekeeping staff and the various waste management handlers. The question is, we are the generators. You can look at, we have the nursing staff, maybe not lab technicians in the OT, the lab technicians, the doctors, whether it's a microbiologist or pathologist. So in fact, all healthcare workers. So who are at risk with these hazards? The generators, and not just the generators, but also the people who are handling it. That was like all the stakeholders who are involved in biomedical waste. So facility staff, environment, obviously, yes. If it is the waste is mixed up, doctors, nurses, patients to some extent, if it is not following the rules and regulations and the guidelines, how we are supposed to have a separate waste collection area in the wards, supporting medical staff, general public also can be affected in this case, obviously through indirect mechanism, and collection and disposal who are involved. And why they're at risk? Can anyone say why we are at risk? That's a big question mark. So now a question to all of you and for all of us to introspect on this. Look at this image. This I took from one of the presentations, and in fact, I used to use it for my regular trainings when I used to train the municipal corporation workers and our nursing staff and housekeeping staff and the interns for biomedical waste management. How many times we see the housekeeping staff or the waste handlers carrying the waste from the wards, from the operation theaters, from the casualty, wearing all these equipments. There's one equipment missing, which has to be the goggles actually. they're supposed to wear the goggles too, which they are not wearing in this particular image. Observe it. And in fact, the gloves also have to be industrial gloves, which are usually red or orange colored ones. The shoes have to be safety shoes like the gum boots, what we see, like in fact, when we are going for trekking on a hilly area with the snow, we are supposed to wear the bigger shoes like that type of shoes. The aprons, not the household clothes. The mask, not the way to wear the mask, but like what I want to highlight is they're supposed to wear the mask too, and the head cap. So I said introspect. Whenever we observe this biomedical waste management, the housekeeping staff carrying the waste, please look at this. And not just during the NABL or the NABH inspection time, probably when everybody is forced. Because as I've said previously, it is all or none phenomenon. You cannot have it 2 days you follow the guidelines and the remaining 363 days you don't follow the guidelines. Okay, an interesting thing over here to share with you with my experience with the housekeeping staff. When we interviewed the housekeeping staff, uh, they used to say like, sir, we find it difficult to wear all the equipments. We find it uncomfortable to wear the gum boots. We don't want to wear the industrial gloves because holding the waste becomes very, very difficult for us. So that's the reason we wear the normal surgical gloves, and we'll be using that to remove the waste from one bin to another bin or collect the waste in central storage area, do the quantification process. Now the question comes is, okay, so is it uh, their discomfort more important in this case, or are they not aware of the hazards involved in this case? Or have we left the biomedical waste management to the people who are the least educated? Or should it be the responsibility of the people who are the most educated in the medical, in the hospital settings? So we need to ensure from hospital infection control committee in the routine audits when we do it regarding how these workers, and the biggest challenge what we face, and again in this case, is the workers also complaining that they don't get these personal protective equipments from the management. So that's where I was at loss what to say. And then when we interviewed the administrators, they said we are providing it. So it was very, very difficult. Either probably I should have go for some focus group discussion with them and find out actually like what is really happening in the field settings. But it was almost universal everywhere, whether it's a government and private sector, where I observed the workers always say they are not feeling comfortable wearing these equipments. So comfort is one, suffering from disease is another, and it's not just them suffering from disease, their families also will be suffering if one of the members is HIV and hepatitis B, which all of us know. The same thing which I was talking to you earlier, the mask, the glasses. Okay, and this always I talk to my students also when we take the classes for them, that when comes to glasses, I tell my students clearly, even if you become a surgeon or obstetrician, any surgical branch you take, please ensure that you wear the goggles or the glasses itself for protection of yourself. Because we're talking about universal precautions. Though, as per NIH protocols, many times we make it mandatory for all the patients to be tested for HIV and hepatitis B. But as we're aware, being in public health and community medicine, the patients, many of them will be in the you can say window period. Many of them may be in the window period when we are testing them for HIV and hepatitis B. And when we're operating them, so look at any of your colleagues who are surgeon or who are in surgical branches. After they come out of the OT, their glasses will be having multiple small, small stains, which is because of the exposure to the various fluids, probably what they would have been exposed to while working in the operation theaters. So it's very important for all the ones who take some surgical branches also, that goggles have to be, you can say, used. Otherwise, we're exposing ourselves to the infectious fluids. This is now almost mandatory wherever we are going for NABH accreditation, that, and we always ensure all the medical colleges that at least hepatitis B immunization should be done for the doctors, for the even the medical students when they're entering into the MBBS. Before they used to go in the second year for clinical postings, and now we have in first year itself as a part of early clinical exposure going into the hospital. So we need to immunize them with hepatitis B minimum at least. And regularly at every 5 years, we need to go for titers also of this thing, the hepatitis B antibodies in the body to see like if it is less than 20 international units per deciliter, then in that case, obviously, we need to go for the booster doses of hepatitis B for all the healthcare workers. Looking at the hazards now, so this I was few I've already highlighted as I talked about the healthcare workers, patients, and the waste collectors. But more it is to the collect people who are collecting the waste, people who are putting the waste in the. I mean, when in many of the visits when we used to do it to the hospital side, looking at the doctors have done the procedure and they have left all the waste what has been generated on the table itself. And then some of either the nursing staff or the housekeeping staff has to come and throw it in the various small bins they used to make it in the trolley. If no trolley mechanism, then they have to carry in a tray and then bring it to the nursing station and throw it in the respective bins. So again, obviously, like it's them who are at more risk. Okay. Now coming to dumping part. So we are aware, okay, fine. Cities have got these big agencies coming up, but like looking at from the primary healthcare perspective, if you look at the guidelines, they have mentioned that okay, in PHC settings, probably we can have a pit near the primary health center where the waste can be thrown, probably can be burnt also. That's what they used to do it. And the sharps can be collected at one place. Later on, whenever the agency comes, they can collect it. But now most of the places, the you can say reach of this agencies has increased. They go to the respective places on a frequent basis and collect the waste depending upon the amount of the waste generated. I'm highlighting amount of the waste generated. Okay. So these are the principles or steps of biomedical waste management, which I have got one of the articles, and WHO. There's a wonderful WHO booklet also on biomedical waste management guidelines. Starting with the most important pillar, I've been telling important time and again, it's a segregation of the waste at the source. If that is there, our headache comes down by 99%. And that's the, I can say the biggest problem what we face is the segregation only, which doesn't happen. Pre-treatment, laboratory and highly infectious waste, yellow waste, the settings which I have observed, I rarely found this pre-treatment thing happening for the infectious waste in this way. But yes, the liquid waste, what we have infectious coming from the labs and all, is treated with the disinfectant fluid before being released into the normal, you can say, the drainage facilities of the institution. But again, it's a requirement of the infection control committee to collect the samples and to be on a safer side from our side itself. I'm both the Department of Microbiology and from HIC team and find out what is the level of the various, you can say, the chemicals in the waste which is being discharged from the hospital, especially from the labs. And that's rarely being done. We do these tests and all, especially when we're talking about the industries, but hospital settings, they're right now, till now, they have not been very strict. Okay. Next comes is collection and storage of segregated waste. So in the hospital settings, one place has been identified. If you look at the International Clinical Epidemiology Network guidelines, they say like this waste bins and bags have to be near the nursing stations. And so one of the findings which we observed in our research that if it is kept at near the toilets, which we have seen in some of the hospitals and institutions, patients throw away their home food or whatever leftover of the food material in that bins only. They will not bother about whether it is your yellow or red or blue, or previously we used to have the black also. Now it is not there, but some of the institutions for general waste, they still use the black color. So it varies from institution to institution. Trying to have it in nursing stations and the capacity, we need to look at different types of bins. We cannot have all, I can say, one for all the wards of the hospital, one type of the waste bins or the bags. Depending upon the waste generation, we need to have a different types of different sizes of the waste bins. Otherwise, the waste bins will not be like the waste will not be, you can say, coming completely filling up to 2/3 or 3/4. Some of the guidelines talk about 2/3 filled, and then we should be tying and carrying the waste to central storage area. Some of them say at least it has to be 3/4. Okay, fine. We around 60 to 70% we have filled, and then we are tying up that waste and then throwing it off. But if the waste is generation is very less, and you have kept the big bins, which we observed in some of the institutions, then they were carrying away the infectious waste after 1 month or 2 months. What is the point of carrying away this waste in after 1 month or 2 months from these places? They said we should take not 1 month is like slightly an exaggeration, I will say. In some of the primary healthcare settings it happens, but in the hospital settings we observed 1 week to maximum 10 days. So waste was being carried because the bins were of the bigger size. Now, coming to intramural transport from the wards, uh, there's one section on the right side of my slide, you can see in the pilferage. We observed in some of the government institutions, I'll not name, uh, this pilferaging was one of the biggest, you can say, problem. So from the wards, when the plastic bottles are going to the central storage area, the bottles were being taken away and sold in the market because you were getting the money for those bottles, higher amount of money. In fact, institution, if they like sell and give it to them, and they'll be in fact paying the money to this collectors, because they will be treating the agencies who collect the waste from the respective hospitals. But for the people, it was like giving the waste to the these vendors who collect the waste, and then money was being paid to them. Okay, that is one. Now, my concern is when during this process, because of some little amount of money, these workers, so they had to focus on that during the trainings also this part. Please don't go for pilfering activity, because you are putting not yourself but also the family members at risk. Okay, now coming to the central storage area. So as I said previously, like it has to be ensured that the waste what is being collected at the central storage area of the hospital should be going the waste from the point of generation to the point of disposal, not take 48 to 72 hours. If it's taking more than that, we are in fact there's multiplication of the organism, everything will be happening. Okay, now coming to your treatment part. So most of the medical colleges and hospitals as of now at present, we do not go for something called as the final disposal. We are having a tie-up with the common agencies. Treatment part of the plastic waste, though, is being done in present settings with the disinfection, that is either hypochlorite or the bleaching powder solutions. And the remaining part is managed at the various at the agency level. So our job when we're looking at starts from segregation to the central storage area of the hospital. Now the question comes is quantification. It was one of the findings of our study when we said wherever we are looking at the pilfering is happening, it's ideal we need to have some quantification of the waste when we are carrying in the trolleys, how much amount of the waste was generated from each ward, and we are labeling it. In fact, later on the guidelines which have come in 2016, they came up that we need to have the bar codings. So barcode for the waste generated from the various hospitals, so they can easily track which hospital is having the mixed waste or which hospital is carrying the waste in a proper way. Then we came up with this quantification concept that at the ward level itself, we are going to have the quantification of the waste. And then when it goes to central storage area, again, we'll have the quantification. It creates more problem, but only in the settings where we are having these issues. Otherwise, most of the places, this quantification process happens at the central storage area, where 24/7, there has to be somebody, or at least two people have to be there in the shifts to collect the waste, observe if there any mixing is there, identify which ward it has been mixed, and report it to the administrator that these wards we are not getting the segregated waste correctly. Again, a very important thing, we don't expect the persons handling and sitting at a central storage area or receiving the waste to segregate the waste again, which is observed in many of the institutions, that they make the workers segregate the mixed waste again. Should never, never, never be done. Okay. Why quantification again? Because The hospitals have to pay, depends upon the number of the beds. So bigger hospitals charge us per bed per day and the hospitalization dates, or some other hospitals will be like smaller hospitals are charged depending upon the amount of the waste unit in terms of the kilograms. So nominal fees will be there. It used to vary like from 5 to 10, almost it comes to 15, 20 rupees per kg per bed per day for the bigger hospitals where almost all the beds are occupied. Otherwise, it will be going in per year, some a few lakhs for the not 600 bedded hospitals, I'll say 300, 400 bedded hospitals, again varying from agency to agency, but it will be going in the few lakhs. Just an example, like how much amount of the money the government is, I mean, we are spending. Assuming like we have 1,000 bed hospital, and in 2009 it was 5 rupees, later in 2016 something it came to 10 to 15 rupees per kg per bed per day. So 1,000 bed hospital, we're talking about 10,000 rupees uh, per day, and 10,000 rupees multiplied by 30. Just think about the amount of the money. So it comes as maybe like 10,000 and 30. Am I right? It is around 3 lakh rupees. 3 lakh rupees for 1 month. And for coming for the entire 1 year, it becomes 36 lakhs. So that's for the bigger hospitals having, you can say, all the beds occupied. So other hospitals, depending upon the waste. So again, it will be like not less than lakhs. It will be in lakhs only when it comes to the biomedical waste for each hospital. So much amount of money is being put for this. And still, if we don't have the segregation mixing, then again, we are creating, you can say, more indirect cost on the public and also for the healthcare workers in terms of the diseases and the injuries. This I'll not go into details, just like the categories of the waste what we have as per 2016 guidelines. Coming to the challenges. So almost this is regarding the COVID-19 point, and you can see one of the workers how he's collecting the waste in the corporation area where the landfill site was there. All the waste masks are being handled directly by the bare hands. So still, I don't really understand whether who is responsible. They are responsible, we are responsible, or the agency or the people who are employing them are responsible. Who is at fault? It's a big question mark. The first challenge, which we already highlighted, proper segregation. No proper segregation. And most of the times we end up like throwing the waste in yellow bins only, thinking that it's going to be burnt and nothing is going to happen. But believe me, plastics being burned, the poisonous toxic gases being released. If you put the general waste, the amount of the cost which the institution is spending on the biomedical waste increases, because again, this incinerator plants, most of them work on diesel. And in Indian context, we don't have such bigger regional common waste management treatment facilities where we can generate electricity and make this incinerator plants more of, you can say, not just using a lot of amount of diesel, but also contributing to generation of electricity, which some of the Western countries have done to that level too. Funds, yes, it's always a challenge when it comes to the funds. So what is the hope for the way forward, or the five-pronged approach, and where our role also comes into play as public health physicians? All the stakeholders, whether it's the administrator, from them to the doctors, to the technicians, to the nursing staff, to the housekeeping staff, we need to train them. Give them the updates what are happening on the guidelines. Capacity building of the team members, how we're supposed to discard the waste. Guidelines. It is one of the very important points the International Clinical Epidemiology Network INCLAN tool also has given, which we had used for our research, that the guidelines have to be displayed at the place, all the nursing stations and the wards where we are keeping this waste bins. If it is not displayed, again, automatically it will be coming as this particular healthcare area was not having the guidelines displayed. So it's our responsibility that the guidelines are displayed. It's more of, I can say, reinforcement than seeing that we at least go for proper segregation of the waste. I think, okay. Then, yes, this is not in our control. Obviously, you can say the government's control, talking about avoiding the monopoly for agencies. to at least ensure that the quality work is happening. And the strict implementation. I think all of you would have read or gone through these guidelines. There's a punishment to the tune of imprisonment of the hospital administrator, and not just the fine. Fine will be varying from few thousands to lakhs also, and depending upon the repeat offense, it will be increasing. And there will be, as I said, imprisonment for the hospital administrator, the medical superintendent, or the director of the institution, which has never happened in the history of the country and will never happen, because when it comes to healthcare settings, they always look at focus should be on more training and training and training. Because if we start putting such a strict laws and rules and regulations, probably people not be starting or opening up the hospitals. But I think it goes in both the ways. We can have for few years, maybe 5 years or 6 years, the educational mode. At some point of time, probably I'll ask the moderator to guide me through this. We need to have the strict implementation of the rules also. The same thing, what we're looking at, the eco-friendly practice means we're talking about more of the recycling material thing. Otherwise, the amount of the waste what is generated post-COVID now, I don't know, sometimes probably we all will be seeing that near outside the cities, many of the villages will be covered with these landfill sites. And may keep on seeing in the newspapers, people keep on complaining that please don't throw the waste or do not have the landfill site in this particular area. So trying to go for the technologies where we can go for more recycling of this waste. And the most important, but still I feel it's the waste segregation in this case. If segregation is correct, our job becomes very, very easy. Now, what is our role as community medicine physician? Few things which I've already highlighted. Do we have a role in this? I used to get a debate from many of my colleagues. What is the role of this thing, the community medicine people in this? Why we should be talking about biomedical waste management? It's the job of the environmental engineers and the biomedical engineers working in the institution. It's a job of, they used to say it's not our job. It's the job of the housekeeping staff. They are the ones who are handling the waste. And it was, you can say, uh, during the HIV trainings, I mean, just slightly deviating a bit, we used to get the counselors who used to say oh, HIV wale sir, HIV wale madam. And in fact, I was called as hospital kude wale sir. So you can say kude wale sir, which used to be a waste management thing. From that, I become the hospital kude wale sir aa rahe hain, jaldi thik karo karke. Wahan par they used to say like that in Hindi when we used to go for supervision or a survey. Yes, we do have a role. And what is our role? We, community medicine team, one of the epidemiologists is a part of the hospital infection control committee. So we have to be a part of the regular audits when it is happening. And audits go hand in hand with development of the standard operating procedure or the manuals for the HIC. And we need to work together. When we talk about public health, it's not about only community medicine. It has to be working with the various departments, in this case, my department of microbiology and the clinical departments in the hospital side. Capacity building, yes, we have a big role, not just capacity building of our own institutions. We can go one step further, working with the government officials and also going for training of the government healthcare workers. And looking at go beyond the hospitals, we can go even talking about the corporation workers also, which I was involved in our trainings for multiple batches of trainings of the corporation workers. We used to carry the waste from the lower end of the hill to climb up the hill and then bring the waste to at one particular point. And research, yes. Researches have been done, multiple and systematic reviews also have been done. But the key challenges, which has, you can say the themes which are coming up from the various narrative reviews and systematic reviews and the studies, everyone points out the same thing, the segregation, and then how the waste handlers, the personal protection or the protective equipments for them, the trainings, the capacity building. So that's where I think our role is there. We should have the knowledge and we should comply by the rules with proper knowledge, planning, and care. Obviously, biological exposure is avoidable. The entire family can be protected. We usually think that HIV is coming down, but beware, please, HIV is again increasing. Let us be safe. Let the waste of the sick not contaminate the lives of the healthy. That's what we look at. Thank you. And these are my acknowledgements to the guide and to my professor in IGMC Shimla and the INCLAN India, who helped us with a lot of tools for the research in biomedical waste management. So that's from my side, sir. Um, Over to you, sir.
Thank you, Dr. Saurabh. It was really engaging and nice. And I really like the approach and the way you started off with the pictures and a lot of practical tips. I think this has been a very, very useful session, and I'm sure that this will be a very useful resource when it is archived on the YouTube channel. Just for the benefit of all the audience who are here, very few are here, but we always put up all these recordings on the YouTube channel of IAPS in Karnataka. So you're free to visit anytime and you can always make use of that. We've had very good reviews and people have, those who have not attended also have visited and sometimes some of them have texted me from different parts of the country saying that they found it very useful and please keep doing such things. So, and again, one more thing is, if at all you have any suggestion, please feel free to reach out to us. We will try and see to it that we will accommodate your request. Now, if you have any questions, I see Dr. Poonam has said, thank you, Dr. Saurabh, and I think I appreciate, Dr. Saurabh, the way you've taken it. Any of the people having any questions, you're most welcome.
Hello.
Swastika, just give us a minute. So if there are no further questions, I presume and assume that it's been clear, okay, and people have found it useful. Let's just hope that everybody finds it useful later as well on the YouTube channel. So thank you, Dr. Saurabh, for spending your valuable time with us, sharing your expertise and experience. And thank you so much for taking up this difficult topic, seemingly difficult topic, but very, very important, as I said in the beginning, and you endorsed it as well. So thank you so much. And I also thank the IAPS in Karnataka chapter, which we've been using the platform of ClearNet. So from our side, on behalf of IAPS in Karnataka chapter, we thank ClearNet and Swastika in particular today for coordinating, and Ritu in absentia for helping us with this, the coordination as well as for the development of the flyer and other things and registration. So thank you so much. Over to you, Swastika.
So, thanks to all the dignitaries present here, client is really glad to have all these brilliant people together in this session today. And I hope you all had a seamless experience. So, with everyone's permission, I'm concluding the session in here for today and looking forward to host you again. Thank you so much.
Thank you.
Thank you. Good night.
Thank you, sir. Thank you, everyone.